Have you ever held your breath while giving your baby peanut butter for the first time? You are not alone. This fear is real, but so is the science that can help you feel more confident in introducing allergenic foods. Hi, I'm Dr. Mona Amin, a board-certified pediatrician mom and your go-to guide for evidence-based parenting. In this video, I'm walking you through 8 things every parent should know about food allergies. These are things I wish every parent knew before starting solids. If you like parenting tips that blend science and real life like a nice puree, go ahead and hit that subscribe button, and let's get into it. Let's start with the basics, terminology, because this one causes a lot of confusion. A food allergy involves the immune system and mistakenly treats a food protein like peanut, milk, or egg as harmful. This can lead to reactions ranging from mild hives to serious issues like difficulty breathing. A food intolerance, on the other hand, affects the digestive system. Think gas, bloating, or tummy upset. It's uncomfortable but not dangerous. A common confusion here is cow's milk protein allergy, or CMPA, versus lactose intolerance. CMPA is an immune response. It can cause blood and stool, vomiting, eczema, and more. Lactose intolerance is rare in babies and involves difficulty digesting milk sugar. More on this in my YouTube video on CMPA. And the top 9 food allergens: milk, egg, peanut, tree nuts, wheat, soy, fish, shellfish, and sesame. These 9 foods account for about 90% of all food allergies, though technically a person can be allergic to almost any food. Let's talk about something that is a reality: the rise in food allergies, and it's not just a perception. Between 1997 and 2011, food allergies in U.S. children rose by nearly 50%. Today, about 1 in 13 kids have a food allergy. That's roughly 2 kids in every classroom. Interestingly, this rise is mostly seen in Western countries like the United States, UK, and Australia. In places like Israel or Thailand, where early exposure to allergenic foods is more common and the cultural norm, the rates are significantly lower. So what's going on? There's no one single cause. The rise in food allergies is multifactorial, driven by a mix of genetics, environment, lifestyle, diet, and changes in how we live and raise our children. Let's break it down. The hygiene hypothesis. We're raising kids in ultra-clean environments. Think antibacterial everything, less outdoor play, and fewer pets. Now compare that to our grandparents who were playing in dirt, shared food with their hands, and were around animals daily. Their immune systems had plenty to keep them busy. Today's immune system, it's like a bored bodyguard with nothing to do, so it picks a fight with harmless things like peanuts or eggs. Next is gut microbiome disruption. Your baby's gut is full of helpful bacteria that train and regulate their immune system. But things like excessive antibiotics, low fiber diets, ultra-processed foods, and even C-section delivery can throw off that balance. And while C-sections are sometimes necessary, mine was, this isn't about guilt. It's about understanding how many small factors over time can possibly lay the foundation for risk. It's usually a combination in an area we're still learning more about. This is about patterns. Food allergies are shaped by many small factors adding up, not one moment or decision. Modern diets and food processing. We're eating more additives, preservatives, and ultra-processed foods and fewer whole, fresh ingredients. That shift can impact both gut health and immune system sensitivity. Environmental and lifestyle changes, more screen time, less dirt, less playing outside, and lower vitamin D exposure. All of that can play a role in impacting the immune response. Genetics and epigenetics. Some kids are more prone to allergies genetically, but genes alone don't explain how fast rates have risen. This is where epigenetics comes in, how our environment and even our grandparents' exposures influence gene expression. Think of it this way: genetics is the piano, epigenetics is how it's played. Everything from diet to stress to environment plays a note. Factors like diet, stress, environment, and even your grandma's experiences during pregnancy may influence how your baby's immune system develops. Next is eczema and the dual allergen exposure hypothesis. And here's a big one. Babies with moderate to severe eczema are more likely to develop food allergies. That's because when food proteins enter through broken skin instead of through the gut, the immune system may flag them as dangerous, leading to a higher likelihood of developing a food allergy when they finally take that by mouth. That's why early oral introduction of allergens is now considered one of our best prevention strategies and good skincare for eczema. But here's the hard truth. Even with all of this knowledge, your child can still develop a food allergy. 2 babies can be born vaginally, breastfed, crawl on the same floor, and only 1 ends up with an allergy. Why? Because immune development is wildly complex. There are layers we don't fully understand yet: genetics, microbiome diversity, timing, exposure, even chance. So if your child has a food allergy, it's not your fault. And if you're here learning and following current guidance, you're doing an amazing job. As a pediatrician and mom, I find this research both humbling and hopeful. We're learning more every year, and I'm here to keep you updated with what matters most. If that sounds like your vibe, hit that subscribe button so you never miss a thing. Let's talk about which babies are more likely to develop a food allergy, because there are a few clear risk factors we look for. First up, moderate to severe eczema. This is one of the strongest predictors of food allergy in infancy. Eczema often means the skin barrier is weakened, allowing food proteins to sneak in through the skin before they are ever eaten. When the immune system meets a food this way through the skin instead of the gut, it may label it as a threat. That's called sensitization. And it's why early oral exposure is so important. Studies like the LEAP trial confirm this. Babies with eczema, especially early on, are at significantly higher risk for a peanut allergy. Next is family history. If a parent or sibling has a food allergy, eczema, or asthma, your baby may be more prone to it too. So the myth, my baby isn't at risk because no one in our family has allergies, is not true. Genetics play a role, but they're not the whole story. Now here's where it gets really helpful. The AAP and NIAID break babies into 3 groups when it comes to peanut allergy prevention. Knowing your baby's group can help you decide whether testing is needed before introducing peanut. Group 1, babies with severe eczema and or known egg allergy. These babies are considered high risk. Testing for peanut allergy is sometimes recommended before introducing peanut products. If testing is negative, your doctor may recommend introducing peanuts between 4 and 6 months in a safe way, sometimes in the office for peace of mind. Group 2, babies with mild to moderate eczema. No testing is needed, but these babies should still begin peanut-containing foods around 6 months of age or earlier if showing signs of readiness, ideally after a quick conversation with your pediatrician for the go-ahead. Group 3, babies with no eczema or food allergies. These babies are considered low risk. Peanut can be introduced at home with solids based on your family's food traditions and preferences. These groups apply mainly to peanut introduction, but they give helpful context for other allergens too. The bottom line, most babies don't need testing, but some do prior to starting solids. And your pediatrician can help you figure that out. This part is huge, and it's where the research gets really interesting. Back in the early 2000s, the advice was to delay giving allergenic foods like peanuts and eggs until a child was 1. But that changed with the LEAP study, short for Learning Early About Peanut Allergy. Here's what they found. Babies at high risk of peanut allergy who started eating peanut-containing foods between 4 to 11 months old were up to 81% less likely to develop an allergy compared to those who avoided peanuts. One major clue came from comparing cultures. Babies in Israel who regularly ate peanut puffs like bamba early on had fewer peanut allergies than babies in the UK, where parents were told to delay. And it wasn't a one-and-done exposure thing. In the study, babies got about 2 grams of peanut protein 3 times a week, roughly 2 teaspoons of peanut butter, or a handful of bamba. Consistent exposure was key. We'll talk more about how to introduce allergens safely in part 2 of this series, so subscribe to my channel so you don't miss a beat. Let's talk about what allergic reactions actually look like, because they're not always immediate or dramatic. There are 2 main types. IgE-mediated reactions. These are the fast classic ones: hives, swelling, vomiting, wheezing. They usually happen within minutes to an hour after eating a food. Some examples are included here. Non-IgE-mediated reactions. These are delayed and often affect the gut. You might see vomiting, diarrhea, or blood in the stool hours or even a day later. One type of this is called FPIES, which causes intense vomiting and dehydration in infants. Make sure to check out this podcast episode on important information on FPIES, which is also on the rise. And then there are biphasic reactions where symptoms go away and then come back hours later. That's why we always recommend heading to the ER if epinephrine was ever used, even if your child seems fine. Let's talk about something that's understandably scary. What if your baby has a reaction? Even just thinking about it can make your heart race. But having a clear plan and knowing what to do can make all the difference. So here's how to handle it. For mild symptoms, if your child has one of any of these symptoms after eating a food, monitor for repetitive reactions. Of note, a rash around the mouth is not necessarily a food allergy, as many babies can develop a contact irritation, especially with acidic foods. So watch for other signs. If your child has more than one of any of these mild symptoms after eating a food, speak to your clinician and hold on this food until you speak with them. For severe symptoms, if your child has any of these severe symptoms, they should be seen in the emergency room right away. Call 911 immediately. If your child has a known allergy and an EpiPen, give it right away. Always go to the ER even if your child starts to seem better. Here's why. Reactions can sometimes have a second wave called a biphasic reaction where symptoms return hours later. The ER is the safest place to monitor and support them if this happens. I get this one a lot from parents. Should we test before trying peanut butter just to be sure? If your baby is in the high-risk group, severe eczema or known egg allergy, yes, talk to your doctor about testing first. They may recommend it or recommend monitored introduction in their office. But if your baby is not in that group, then testing is not recommended. That's because skin and blood allergy tests can have false positives. Your baby could test positive without actually reacting to the food. Testing is more helpful when there's a history of symptoms or a strong medical reason to dig deeper. And if you want to learn more about how food allergy testing works, including things like oral challenges, I dive into this in detail on my podcast with a well-renowned pediatric allergist. Check the episode in the description below. A food allergy diagnosis can feel overwhelming, but there's good news that many kids, especially those with milk, egg, or wheat allergies, may outgrow them with time. About 80% of kids with milk or egg allergy outgrow it by the age of 5 or 6. Wheat and soy are also commonly outgrown. Peanut, tree nut, and shellfish allergies tend to be lifelong. A pediatric allergist can help guide when and how to reintroduce foods, often with a supervised oral challenge. In the meantime, label reading becomes second nature. Teaching caregivers how to recognize reactions and use an EpiPen builds your support system. I also had an amazing heart-to-heart podcast conversation with Asian Allergy Mom, that's her Instagram handle, about real-world management from daycare to school to emotional bandwidth. Let's wrap this up with a few key takeaways. Food allergies are rising, and it's not due to one single thing. It's complex and evolving. Babies with eczema, especially severe, are at higher risk. Typical allergic reactions happen within 10 minutes to an hour after ingestion of the food and are not going to happen during the first exposure. Testing is only recommended for high-risk babies or after a concerning reaction. Many allergies, especially in young kids, can be outgrown. But most of all, food allergies are not your fault. They don't mean you did anything wrong. Every immune system writes its own story. The more you know, the more confident you'll feel navigating this journey, and I'll be here to walk you through it. Let me know in the comments what surprised you the most about this conversation or what helped ease your mind. If this video helped, give it that big thumbs up sign, share it with a friend and on your social media channels, and subscribe because in part 2 we'll talk all about how to introduce allergens safely, when to start, how often. You're learning, you're showing up here, and that's what matters. I'm so grateful that we are on this journey together. See you all in the next video.